Hey guys, thanks for taking a few moments to check out this video that I made. A couple reasons for making this is one, obviously to review some of those points that I sent out on the document on how to manage some of these critical care patients with COVID. And two, I just want to take this opportunity to try out a new platform for some online training. I think this could be really useful in the future for some CEs, continuing education, things like that. So just to let you guys know, all the information that I gathered, I attached some of the resources on that document where I found this information. Please feel free to check it out, watch the videos. I might explain some more things in depth. And please feel free to fact check me. If you guys have any concerns or questions about these bullet points, please bring them up to me. Just so you guys know, I collected all of this data, put it together, and I sent it up to some admin members, those who are running point on COVID deployment, and to EMS and resource. Chief Malcolm has forwarded this to our medical director who's approved it. And just recently, Malcolm sent out Arizona DHS's protocols for how to manage COVID. And a lot of those points do coincide with what I'm about to cover. So nothing is really outside of our protocol. The only thing that is really different than protocol would probably be the use of the SVN, but as we know, there have been a lot of recommendations now not to use it or be very careful when and where to use it. And like anything else, Malcolm sent out another email stating that we, of course, have to follow our protocols. If we feel it is necessary to go outside of our protocols, then please, 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 beforehand, call a doctor, get medical direction, get their permission, and then document appropriately, okay? So I'm gonna go ahead and screen share here, show some documents. Give me one moment. All right, so here's a document that I sent out. The reason why I put this together, a lot of documents that I've seen coming out lately have all involved the use of PPE, which is great, but nothing really clarified how we're supposed to manage these patients, okay? So again, did some research over a few days, compiled some stuff, and I think a lot of these points can be helpful. Now, keep in mind, I do understand not all COVID patients are going to be critical care. A lot of people will have much more mild types of signs and symptoms. However, there are patients, especially those older patients that are immunosuppressed, could become very critical, especially with airway management. So that's where these came from. And I hope that these points will help you in your management, okay? Number one here, talking about viral filters. If we are doing anything with BVMs, ventilators, CPAP, the use of SVNs, if we can try to get a viral filter placed in that circuit, that would reduce our exposure risk dramatically. I've talked to Joe and Malcolm and Stockley. They actually were able to find some of these and they've got them ordered. They should be coming in the next couple of weeks, I was told. So if you have to utilize an advanced type of an airway, please put these viral filters on. If you happen to do an interfacility transport and they're utilizing one of these devices, make sure that they have a viral filter. I've attached some pictures in the other document that has a picture of these viral filters that they're using at West Valley or Abrazo Buckeye. So if they don't have one in place, ask for it, all right? Number two, if you have to disconnect the BVM, the CPAP, or the ventilator circuit for any reason, again, there should be a viral filter in place. When you make a disconnect, make sure that it's on the opposite side of the patient, okay? We want to keep that viral filter in place by their mask or their tube. So any kind of exhaled secretions and viral particles are not being exposed to us in the environment we're in. If you don't have a viral filter, then it's recommended that you clamp your tube if you're utilizing an advanced airway. To do that, though, you're going to take some kind of a hemostat, which of course we don't carry. This would be more of a hospital setting. But clamp the tube. This is going to give you a couple benefits. One, it's going to maintain the PEEP and all the recruitment that you've got within your alveoli. Okay, one of the biggest things these people suffer from is a lack of PEEP, and that's why they deoxygenate so rapidly. So if we clamp that tube, it holds the pressure within their lungs while we make a quick disconnect or switch the patient over, or we're transferring them over to a bed or gurney or into the ambo. However, if we just clamp the tube on its own, it's likely that we could crack or damage that tube. So in order to protect it, we want to take some 4x4s, wrap it around, or wrap the tube with some tape, and then we can clamp over that, and it seems to protect it pretty well, okay? Number three, if you have to use a non-rebreather, you can do so. However, we don't really recommend using 15 liters per minute unless your patient needs it. If your patient's still satting fairly well, let's try to knock that liter flow down, maybe to about 10 liters per minute. This will still keep them from recycling their end-tidal CO2, but at least deliver enough oxygen to keep those sats up. So bring down to 10, because if we keep it at 15, it's just going to be blasting past the mask. And again, all those viral particles are going to be up in the environment and exposing us. If they only need a nasal cannula, according to those DHS protocols, they actually want us to maintain O2 sats greater or equal to 88%. If we can do that utilizing nasal cannula less than 6 liters, then we're okay. And this is definitely something that varies from our normal treatment. We usually like to see something over 90%, at least usually 94% if we can, but they're even recommending 88%. There have been some cases, a lot of cases, where patients become hypoxic and providers more in the hospital setting have elected to RSI, put the patient down and intubate them. Well, in doing so, you change the dynamics drastically within the lungs. You go from a negative pressure ventilation to a positive pressure. You lose that natural PEEP within your lungs. And these patients have actually deteriorated pretty rapidly, and they have a lot of problems with oxygenation. So if your patient's at least awake, talking to you, they're alert and oriented, and they're following commands, maybe we can hold off on intubating these patients, okay? And it's been recommended to possibly use something like CPAP. And the way I see it, it's no different than treating your CHF patient. Instead of jumping straight to intubation, let's throw the CPAP on them, and maybe that will help prevent them from requiring intubation. Now, of course, if your patient becomes altered, unconscious, or can't maintain their own airway, then yes, CPAP would now be contraindicated, and we would have to jump to intubation. So do whatever is appropriate for your patient. With SVN use, we should not be using SVNs if your patients can tolerate and get away without it. If they have an MDI, let's definitely use that before we use an SVN. If we do need to use the SVN, let's remove those patients outside in the fresh air, and definitely have us stand back and away from the patient while they get that treatment. Now, if you believe your patient is critical and they need to be transported rapidly, then forgo the SVN. Okay, but we definitely don't want you doing SVNs in the back of a confined ambulance. And protocols have also stated not to deliver the SVN as you're going into public spaces, like walking through the halls of the ER at the hospital. So if you have to forgo the SVN, let's start thinking about using IM drugs like Epi, same dose that you would use for your anaphylaxis, 0.3 milligrams IM, or think about jumping to your mag sulfate as well and running that infusion. It's been recommended, number 6 here, not to use Solumedrol. Apparently it kind of hinders your immune system, so we'll avoid using that. And number 7, with fluid administration. So a lot of these patients will kind of present similar to sepsis. Our goal is to maintain systolic blood pressures well over 90 systolic, okay? If their pressures are normal, we probably cannot, we don't have to do an IV in the field, okay? Just monitor the patient. If we need to start an IV, we can. Just understand that we are we're in close proximity to this patient, we're more exposed. So if they don't need an IV for fluids or medications, then we don't necessarily need to give them. Especially right now in a time where resources and equipment are so scarce, we might want to just hang on to our equipment unless we need to use it on a patient, right? Now, when you choose to give a fluid bolus to a patient with COVID, understand that COVID attaches to receptors within the lungs, okay? The angiotensin II receptors. And this causes the lungs or the alveoli to become more permeable, and they leak a lot more. So you can develop pulmonary edema pretty quickly. So again, be very careful with your fluid boluses, only give what they need, and try just to maintain those pressures over 90. Again, CPAP tends to be a really good non-invasive form of ventilation, okay? Assuming we have a viral mask attached to it or a viral filter. That way it's more of a closed system. We're not exposing ourselves. CPAP is going to help with that peak pressure within their lungs to help them oxygenate. Now, if we have to place an SVN in line with this, I'll show you a picture on how we can still do that and still maintain the viral filter in place. The biggest thing there is you don't want to put the SVN, then the filter, and then the patient, because the filter will still filter out any of your medication coming from the SVN line. So make sure that we put the patient's mask and then your SVN and then your filter on the farthest side of that. Number 9, the use of PEEP is going to be fairly critical with these patients, okay? Again, PEEP is going to help with oxygenation. We want to help stent those alveoli open. However, with the current BVMs that we carry, we have primarily the pink smart bags. Those bags are great for preventing us to hyperventilate. However, there's no adapter on there to put a PEEP valve on. So I'm trying to see if we can get it approved and then get ordered more of those regular white clearish looking BVMs, because those have the adapter for it. As of right now, it's just the pediatric BVMs that can fit it. The pink ones will not. But if you're at a hospital, if you're doing an interfacility, if you have to use a BVM, or maybe Buckeye Valley has one available, see if they got it, grab it, throw a PEEP valve on there. Remember, for current protocols, we can't really go above 5 on our PEEP. But those devices do go up to 20 of PEEP. So if you had a medical direction and they told you to give them more because the patient's not oxygenating well, we might be able to follow those orders and go a little bit higher than our normal 5 of PEEP. With number 10, with any kind of aerosolized measures, the SVN, CPAP, BVM, CPR, ventilators, all of that is going to greatly increase our risk of exposure, because now we're just spewing more viral particles around in the environment. We don't want to breathe those in. So just be aware of that and use all of your precautions, whatever you possibly can, to protect yourself. So with that being said, number 11 here, if we do run on a code and it's suspected to be COVID in nature, we should pretty much be treating all codes as COVID likely at this point. Okay, it's kind of like a triage situation right now. Wear all your PPE. Make sure that that includes your gloves, your full body suit, booties, gloves, mask, and eye pro. Okay, keep in mind that we have to protect ourselves before we can start taking care of patients. Okay, because if we get exposed and we get sick, then we're pulled out and we're not able to continue care for other patients. Okay, so protect yourself. And like one of the recent comments that I believe Chief Agerman made in an email was, we're not going to run into a fire without all of our PPE on. Okay, you're going to put all your gear on before you go into that hazard zone. This is no different. Put all your exposure protection gear on before you enter that room or that space and provide care. Keep in mind, as we're doing compressions, we are pushing more air out of their airway, which again is exposing us more to this viral COVID. So if you're doing CCR, definitely get a mask on that patient. If you have to use adjuncts, I would probably just jump straight to an eye gel. Intubation at this point, this goes with number 12. Intubation pretty much is obsolete when it comes to COVID, okay? I'm coming from a guy who I absolutely believe in taking a first look and at least attempting with an ET tube initially. Right now, it's probably best if we just go straight to an eye gel. Now, keep in mind, there are some patients that still are going to require the use of an ET tube or even a crike, those patients being burned, anaphylaxis, laryngeal trauma, and choking, okay? Those type of patients still need plastic between the cords, but most other patients would probably be just fine with your eye gels or some other form of supraglottic airway. With number 13 here, lots of varying cases with these COVID patients, okay? Some of them appear to be fairly stable and then very quickly they become unstable. Or some might present looking pretty sick and unhealthy. And we talked about some of that earlier. If these patients are still awake and alert and maintaining their airway and still following commands, let's do everything we can to manage their airway, but not be so quick to jump to that intubation or the RSI sequence, okay? Not that we can do it, but something to consider with airway management. Try your CPAP, try more BLS techniques before we jump into our ALS techniques. Again, make sure that we're utilizing PEEP if we possibly can, okay? A lot of these airways will present like ARDS, acute respiratory disease syndrome. The alveoli are collapsing, they're shunting down. So the use of PEEP is going to help pop those alveoli open, stent them open, which allows good surface area and is going to allow that process of diffusion to occur. So keep them pressurized. Again, if we have to disconnect a BVM or a vent circuit from some kind of advanced airway, make sure that we're crimping that tube if we are able to try to maintain that PEEP within their lungs, okay? Even a quick disconnect to move a patient, that's enough time to lose all that recruitment. And you can't just throw the BVM or vent back on them and get that recruitment right away. It takes time to build up this pressure, open up all those alveoli, and keep them open, okay? So try to maintain that PEEP whenever possible. Now, a quick note when it comes to some of this airway management. Draw this out. We know that with end-tidal CO2, our normal should range from 35 to 45, correct? We also know that if we hyperventilate, either the patient hyperventilates or we're bagging too quickly, we're going to drive that end-tidal down, okay? Whereas if we bag too slowly, or they're becoming closer and closer to apnea, we're going to start rising our CO2, all right? And keep in mind, if we have an end-tidal greater than 55, okay, that's actually one criteria for respiratory failure. So anything higher than that, they are not able to exchange their gases properly. They are starting to fail with that respiratory drive, okay? So keep that in mind. Now, if we want to manage our end-tidals, let's say they're not where they need to be, okay? We're managing somebody with an advanced airway, BVM or a ventilator, okay? You got to look at that end-tidal right away, see what kind of norms they're in. Now, in our EMS world, we're not used to using ventilators. All we have is our manual BVM, okay? There is no idea to know how much volume we're squeezing, and it varies every single breath, okay? But we can do a fairly good job of counting and being very rhythmic and on point with our timing of bagging, okay? But our volume might vary. Now, if you're using a ventilator, now that all changes. We can dial in exactly how much volume we want to give. If we want to alter end-tidal, we want to actually change their minute volume. And if we recall, the minute volume equation is tidal volume times respiratory rate. Okay, right now with the BVM, we can only really manage that. But if we are able to use a ventilator, tidal volume would actually be the best thing to alter first, okay? If you get into a lot of respiratory therapist type equations, they're really long drawn out equations, you'll see that tidal volume actually makes the faster, better changes, okay? Now keep in mind, that being said, we have to keep our patients in a normal range of tidal volume, okay? Typically tidal volume would be 4 to 6 cc's per kilo, okay? That's what we usually would start with. Correction, sorry, 6 to 8 cc's per kilo. 4 to 6 is typically what we'd use more for your asthmatics and COPD type patients, but normal goes 6 to 8 cc's per kilo, okay? Now, this is based off of ideal body weight, and without getting into formulas for that, if you have a large obese patient that is much larger than what they normally should be, okay? Just because they are fluffier doesn't mean that their lungs are bigger than somebody of more adequate height and weight, okay? So with those obese type patients, just kind of look at more of their height and figure what you think a normal skeletal type structure they have and what you think that ideal body weight would be, okay? Whereas if they seem to be a normal height and weight for their age, then we can go off whatever weight they are, okay? Just to keep things really simple at this point. Remember, 6 to 8 cc's per kilo would be appropriate. Typically, if we're using a BVM on a BLS airway, remember we're doing one breath every 5 to 6 seconds for adults, okay? That's typically gonna be 10 to 12 breaths per minute, okay? If we're setting them up on an ALS airway, either supraglottic or ET, typically that changes to one breath every 6 to 8 seconds or 8 to 10 breaths per minute, okay? If you are working with a ventilator, usually setting a rate of about 6 to 20 a minute is probably a good starting point, okay? But we're always going to be utilizing the end tidal to kind of drive which way we want to go with our rates and our volumes, right? So first things first, make sure that your patient is having adequate volume. And for us, that would just be good, having good rise and fall, some good lung sounds equally throughout. And then we can alter our rate if we want to change that end tidal. Remember, if we go faster with our rate or higher on our volume, we're going to drive the CO2 down. If we slow things down or if we minimize our volume, we're going to start to see that end tidal creeping up. Okay. Now, CO2 is managing ventilation. If we want to optimize oxygenation, okay, if we want to increase SpO2, we have to maximize or increase their FiO2, and we have to look at PEEP. Okay, so FiO2, basically to keep things simple for us with how short our transport times are, just put them at 100%, okay? Whatever device you're using, 15 or greater liters per minute with like your BVM or your ventilator, if it has that setting, we would put that at basically 100% or an FiO2 of 1. And then with our PEEP, like I mentioned, right now, if we're utilizing our BVMs and our PEEP valves, we kind of want to keep that at about 5. All right, they do range and go up to about 20, but we don't really want to go over 5 unless we have that medical direction on that to do so. Okay, so let's go to a couple pictures real quick. And these are going to be in those video links that I've attached. There's going to be some talk of utilizing possibly inline suction devices here, okay? Again, once we have a patient with an advanced airway, we really don't want to break that seal ever if we can help it, okay? So we're looking at possibly, first it's got to be approved, and then maybe if it's available, or if you have that interfacility transport, maybe we can get an inline suction device, okay? This whole device here still allows us to connect to their airway. We can connect a circuit, or in our case, a BVM, and then we can apply the suction. This is going to keep the suction catheter sterile for our patients. It eliminates us, requiring us to break that circuit to put a new catheter into suction. And that's going to eliminate anything coming out of that tube and exposing us in the environment. Okay, so if you can use this, that would be awesome. Now looking at this right picture of the PEEP valve, keep in mind, we just got to twist this around to get to 5. And we're always going to measure at the base of this cap. Wherever that sits, that's how much PEEP we have. So dial it until this is up to 5. More if a doctor orders it. Remember, it only works on these kind of white, clearish looking BVMs, not the pink smart bags. And all you would do is pop the cap off the end of your BVM and just plug it right into there, okay? Now looking at a ventilator setup, you can see that we got a viral filter hooked up right here immediately out of the mask before it goes into the circuit, okay? And then this particular setup, they actually put a viral filter at the vent and one over here by the patient. So they're using dual filters. Now, some of those videos will show you a setup that looks something like this, okay, where they have the mask set up to a filter. Now, this device right here is actually their end tidal device. We don't have an end tidal with a lure lock system like this, right? Our end tidals are already built in with the tubing. So we'll talk about this in a second. But ideally, we can put our end tidal right here if we still want to monitor end tidal CO2. BVM attaches to that. We got our PEEP valve involved, okay? Now, if we don't have the ability to provide CPAP, because for some reason, maybe we're low on stock, we don't have any more, but you believe your patient can benefit from CPAP, okay? If we're able to get a mask and maybe those hooks that go on the end of the mask and with a strap, what we could do is just tightly secure a mask to their face, okay? And we can utilize this BVM setup to essentially create CPAP for them, okay? The only way to do that, though, if you watch the video, they're going to put a nasal cannula on the patient first, set that to about 4 to 6 liters, because within the circuit, you need at least that 4 to 6 liters to kind of activate this PEEP valve. It's all spring loaded, okay? What they're doing in this system is some people were concerned about a nasal cannula being on and then a mask sitting over that because it would create potentially a tiny leak on the side of the mask, which is then still exposing our environment. So they ended up hooking up this whole Luer lock and tidal system to O2 tubing to apply their O2. We don't have that set up, so we're probably not gonna be able to do that. We're still gonna have to apply a nasal cannula to the patient, put our CPAP mask on them, apply our viral filter, and then when we hook up our BVM, we set our PEEP to 5, and I would run my BVM at as high as we possibly can on our regulators, at least 15 up to 25 liters per minute if we can. That's the flush rate. And so that will create enough pressure and O2 in here where when the patient decides to trigger their own breath and inhale, they're going to be getting that pressurized oxygen coming through the system, okay? And then when they exhale, it's protecting us with this filter. All right, that'd probably be a pretty good setup. If we wanted to, we can add some flex tubing in here. You may have to play with some adapter pieces depending on how it fits, but at least that would give you a little bit more play in moving your BVM around so it's not fixed, like hard fixed here to the patient's mask. Just a quick, easy setup. If you're not utilizing any other kind of cannula, you're just trying to simply ventilate your patient if they need it. Again, folding a tight seal, try not to keep moving the BVM off their face, keep their face covered to protect us, and just to keep a good seal for their airway, apply your viral filter, and then your BVM, and then you would apply your PEEP here at the end. Now, this is the use of the SVN. If you decide that you need to give your patient an SVN, and maybe you do decide you need to give it during transport in the back of your ambo, this would probably be the best way to do it to eliminate exposure to us, okay, and anybody else in the ambo. So get that fixed tight mask to their face, the CPAP mask. We can apply our SVN now in between the mask in this filter. Okay, keep in mind, if I were to put my viral filter in the middle here, then anything coming out of my SVN is gonna be filtered as well. So we're not actually gonna deliver the medication to the patient. So make sure that we're able to get the patient the albuterol and atropine that they need, but any kind of exhaled air is gonna be blocked by our filter. That's pretty much it. I highly recommend that you guys go ahead and watch those videos and look at those attachments that I have in the documents, look at the bullet points. And again, if you guys have any concerns, questions, thoughts, if you find something to be incorrect, please, please, please notify me right away. Let me know, and I'll be sure to forward that information. And keep in mind that this is still a very new process for all of our agencies and with healthcare as a whole. So we're still learning and creating new things and how to manage these patients. We're still learning exactly how the pathophysiology works. So management is going to change and new things are going to come about. So please feel free to share your information. Again, if you have concerns, let me know. With that, thanks for joining us. Oh, and let me know what you think of this training too. If this is something you think we can utilize later for other topics, I think it'd be great. Just let me know. Thank you.